Hi everyone and welcome to Anesthesia Coffee Break. I'm here again with Archit to go through venous admixture and shunt. How you doing?
Hey everyone, nice to be back.
Hey, let's crack on. So venous admixture, actually, this is one of my favorite concepts because it's a theoretical concept and
Mm.
it's just really interesting. There's lots of ways you can go into this and talk about it, and it's just extremely relevant to practical anesthesia. So, Archie, let's get a definition. What is this mystical venous admixture?
Yeah, okay. So tell me what I need to add to this
Yeah,
definition. So for me, venous admixture is the theoretical, as we said, theoretical amount of mixed venous blood that would be needed to be added to that end pulmonary capillary blood to account for the observed difference in oxygenation from that end capillary pulmonary blood to the systemic blood that we see.
great. Okay, so and we talked about mixed venous. Where do you get mixed venous blood from? Or how do you get it?
So you get your mixed venous blood from your PA catheter, which is like your pulmonary arterial catheter.
Yeah, great. So the pulmonary artery catheter, it's like, you put a central line in, then you put this really long line, and that curves through the SPC into the right atrium, into the right ventricle, into the pulmonary artery. So imagine the inputs from you know, I guess your circulations, your SVC, your IVC, that's all mixing. Just remember,
Mm,
if you take a sample from just the internal jugular vein or down in the inferior vena cava, that's just separate parts of the body. It has to mix first. That's why you need it to mix through the ventricle into the pulmonary artery. And that's where you want to sample this blood. So that's where
mm,
you get mixed venous blood.
yeah.
Uh, good. So what are the components? Like what is venous admixture made of?
So a lot of the times, you have this venous admixture that's sort of interchangeably used with shunt. It's not necessarily true. Shunt is a big component to venous admixture, but it also encompasses VQ mismatching that we'll talk about.
Yeah, great. So what we got there, let's go through definitions then. What is shunt? So venous admixture is your headline. Then
Yep.
you've got shunt and you've got VQ mismatch. So venous admixture is made up of shunt and VQ mismatch. So let's talk about what is a definition of shunt.
So shunt, West defines shunt as blood that enters the arterial system without going through ventilated areas of the lung.
Beautiful. That's so easy. You just want a simple definition like that. Blood that enters the arterial system without bypassing ventilated regions. That means that it can't contribute to any gas exchange. That blood, which is deoxygenated venous blood, doesn't contact any oxygen particles. It doesn't get loaded with oxygen. So it completely bypasses and it really affects your saturations at the end of the road down into the arterial system. So it's a
Yep.
real problem. That's good. So that's what shunt is. What are the different kinds of shunt?
So this is from Basic Physiology for Anaesthetics by Chalmers. So there's physiological shunt, which encompasses the anatomical shunt. So anatomical shunts have these two aspects to it, which are your bronchial veins. One is your bronchial veins. So bronchial veins probably contribute to about sort of no more than 1% of your total cardiac output. These come from the aorta. Realistically, they're not that enormous, but again, as I said, it's about 1%, and they don't undergo any of this ventilation. So bronchial veins is one, and then
Right.
you've got your
And just to stay on that. So these veins, so the whole point of the bronchial circulation is to supply oxygen to the bronchial tree. It's
yep.
also not necessary. So you'll find that patients with lung transplants, they don't reconnect the bronchial circulation.
Mm,
That's completely not transferred, unlike the whole pulmonary circulation, which is absolutely necessary. Your life depends on it. So, the bronchial system is not that necessary. It's people survive without it, as proven through heart-lung transplants.
yeah, exactly. That's a great point. And then you've got your Thebesian veins. So Thebesian veins are little tiny valvulus veins in the walls of our cardiac chambers. Their contribution is pretty low to blood flow, but the oxygen content here is really low. So that impacts on our AA gradient and thus reducing the amount of oxygenation that goes through as well.
Yeah, good. So Thebesian veins, they pretty much, the heart muscle extracts so much oxygen, and the Thebesian veins really to take venous blood and bring it back into the circulation. But sadly, they also bypass, so they're going into the left side of the circulation. They're not entering into the right side to then go through the pulmonary circulation and get oxygenated again. So anatomical shunt is bronchial veins and Thebesian veins. The next part of it you said is pathological shunt. Tell me about that.
Yeah, pathological shunt, as the name suggests, is the pathological states that contribute to the shunt. So the big one is your intracardiac shunts. So we've heard about your congenital heart diseases where your right to left shunting allows the blood from the right side of the heart to be ejected into the left circulation, and that bypasses the lung completely.
Great. So this could be any of your ASDs and your VSDs, but often it's not a big part until your right pressures go up or your left pressures go down, as can happen in things like Eisenmenger syndrome. So there's lots of different types of congenital heart disease. Don't worry too much. Just know as a broad thing, certain congenital heart disease can contribute to a lot of intracardiac shunt, especially as these diseases progress and get worse and worse. What else?
So you've also got your intrapulmonary AVMs or fistulas. So they do exactly the same thing as what we just talked about with the intracardiac shunt, whereby you're just going to pass that blood on to the left side of the circulation without undergoing much or any ventilation or gas exchange.
Right.
You've also got, sorry, go.
Yeah, so that's a malformation. Like you're literally having a odd thing happening in the lungs where arteries are then going straight into the systemic circulation, bypassing the lung. So yeah, that's an odd situation, not normal.
Yeah, and I guess the other one is where you've got these angiogenesis around sort of the lung tumors. If they're great enough, that could also contribute to similar things. Is that?
I haven't really seen so much of that, but yeah, as soon as there's any kind of weird pathology in the lung, it contributes to a non-normal state. And so you can imagine all kinds of things could be happening, and that will be a problem and increase.
Yeah. The other one is pneumonia, whereby a really, really bad pneumonia where you've got sort of a lot of consolidation within the alveoli that no gas exchange can happen, could contribute to that shunt as well.
Great. So broadly speaking, this is any kind of pulmonary process that blocks off an alveolus completely. So think of, and it's hard to know. So I don't know how much consolidation pneumonia gives, whether it's an absolute thing in lots of alveoli, just one alveolus, or however it is. But think of anything; it could be a whole bunch of pulmonary edema, aspiration of large volumes or chunks of material from the gastric, from the stomach. It could be severe asthma that's just completely blocked off through bronchospasm, completely blocked off a segment. So you can imagine these things completely block off an alveolus or alveoli. Therefore, there's no gas going to the alveolus. Therefore, any blood that passes that alveolus is not being oxygenated. So that would be any kind of lung disease that contributes to it.
Yeah.
Cool. So that is all of your shunt. Shunt is arterial blood that bypasses ventilation. It's physiological, which means anatomical stuff, bronchial veins, Thebesian veins. It's pathological, intracardiac shunts, pulmonary AVMs and other abnormalities, and intrapulmonary shunts or severe lung disease that blocks off alveoli.
Yeah.
That shunt, what's the next part of this equation?
Yeah, so we talked about that shunt plus VQ mismatch or VQ scatter, as what it's called in a lot of the textbooks around. So these are lung regions which have VQ ratio less than 1, which means that adding up all these little lung units that you say that don't have sufficient or the VQ of 1 will add up to contributing to this venous admixture.
Yeah, that's great. And this goes back to how gas and how perfusion and ventilation changes from the top to the bottom of the lung. There's lots of things that happen, but essentially ventilation and perfusion both increase, but at different rates. Therefore, there's a lot of different ratios of the VQ matching throughout the lungs. When it's less than 1, it's suboptimal. Now, interestingly, at the top of the lung, so if in an erect patient, at the apex of the lung, you have high VQ portions. So actually, if you've got high VQ ratios at the top and low VQ ratios at the bottom. Why doesn't it balance out? Why doesn't the high VQ ratios make up for the low VQ ratios at the bottom?
I think there's a lot more of the low VQ ratios compared to the high VQ ratios, probably because of the hydrostatic pressure or
right. That's exactly right. So if you just stop there, the way I'd phrase it is there's a lot more blood flow in the
Yeah.
bottom, and like exactly what you said. So there's more blood flow taking the low VQ blood, and that you can't overcome the high VQ blood and high oxygenation levels with high PO2s just can't compensate for it. Great. So I mean that's pretty much venous admixture. So the next thing is, how do we quantify this? And there's some experimental ways that we could do this. Do you want to go through that?
Yeah, so the big thing here is the shunt equation, right? The shunt equation is what we're talking about. It is, I guess, when you're starting off looking at the shunt equation, it can be quite intimidating. There's a really good video which I found was great, was through this, I guess, on YouTube through Primary Concepts, where they take you through the derivation of the whole shunt equation. But do you want me to go through the shunt equation now, Lahira?
Yeah, and I'll even put it up for. So if you watch this on YouTube, I'll put up the shunt equation. Again, this is a diagram straight out of West's, so full credit to all the great work that West's has done in the past. And now I think it's taken over by some of his proteges, Lum, for example. Yeah, great. So this is the shunt. This is the shunt equation, QS over QT, and it's got a whole bunch of funny letters and numbers. Let's go through that. What it's all about.
So firstly, looking at this, it's a ratio. So it's Q is denoted by the total the flow. So QS is the portion of the flow which is shunted over QT, which is your total flow. So it's a ratio. So this ratio is C prime O2 minus CA O2, which is your end capillary O2 content, not your partial pressure, your content, which we will get into in a second.
And so C prime, for everyone who's watching, that means end capillary. So capillary and end, it's a C prime. So yeah, good. It's definitely that content of end capillary blood. Keep going.
Yep. So end capillary blood, take away. This is the numerator. End capillary blood, take away arterial O2 content, all divided by end capillary O2 content, take away mixed venous content.
Beautiful.
Of O2.
Now, in our exam, they really try to get you to, how would you get these numbers? So what is the content equation? Because we'll need to use the content equation for all of these, to calculate content.
Yeah, perfect. So the content equation is worked out through this formula. I conceptualize in my head as to how oxygen is actually carried in my head. So the oxygen is carried in around in the body through hemoglobin, and then there's dissolved. So the hemoglobin component of this formula is SpO2 times the hemoglobin content, how much hemoglobin is there, times this Huffner's constant. So you'd see this 1.39 or 1.34. And why is there a difference, Lahiri?
Oh yeah, so the difference is because that there's different kinds of hemoglobin. For example, even in healthy, adult people, there'll be fetal hemoglobin, for example, and so that's just to account for that and it's an approximation.
Yeah, and then we've got that hemoglobin content in there, plus what your arterial PaO2 times 0.003, which is because of the units that we work with in Australia. So altogether, it's SpO2 times the concentration of hemoglobin times your Huffner's constant, which is most of the time it's going to be 0.13, added to your PaO2 times 0.003, which will give you the content in mils per deciliter.
Fantastic. I'm just going to put that up on the screen as well, so we have something to look at. Okay, so everyone can hopefully see this. Sats, like you mentioned, times your concentration of hemoglobin. This is in grams per deciliter, means that your hemoglobin is roughly going to be 15. So let's kind of plug a few of these things in. So if you imagine sats are 100%, that's just, 1 times 15 grams per deciliter, so normal hemoglobin, times 1.34, we have 20 approximately. That's your oxygen in mils per deciliter that's bound to hemoglobin. And that makes a lot of sense, right? Hemoglobin times a constant times a saturation percentage. So if I only had 50% saturation of hemoglobin, which would be obviously very dire, that'd be 0.5 times 15 grams per deciliter hemoglobin times 1.34. And as you can imagine, that'll be around 10 mils per deciliter. This PaO2, that's just your, that's your, pressure in your arterial system. Times that by 0.003. So again, normal PaO2 would be 100 times 0.003 equals 0.3. So roughly, let's say 20.3 mils per deciliter at standard conditions in healthy people with 100% saturations. But just look at the difference, right? Hemoglobin bound, oxygen bound to hemoglobin is 20 mils per deciliter versus 0.3 mils. So your dissolved oxygen in mils is just so small compared to the amount bound to hemoglobin. That's pretty much what we want to say with that.
Shall we get on to how we work out these, where we get these things from?
Yeah, go for it.
So,
Actually, that's exactly right. So actually go through the equation. How do you get each of these components in real life?
yeah, okay, cool. So your CC prime O2, which is your end capillary blood, we'll leave that for a second. Your CaO2, which is your oxygen content in your arterial blood, you can get that from an ABG. So get whatever we've got from the ABG and plug it into that equation. You'll get that formula.
And just quickly, the sats are the easiest thing, right? So
yeah,
you just get your saturations. Boom, that you've got that already. Where do you get HB from?
oh, you can get it from your gas, or you can get it from your blood or whatever.
Fantastic, exactly. So HB from your gas, sats from your sats probe. PaO2 was from your ABG as well. And then you got a constant. So you know exactly how to get all your values. So now you can get content of your CaO2 content in your arterial blood.
Yep, perfect.
Yeah.
Your CVO2, as we've already discussed, is your mixed venous blood, which you can get from your PA catheter, which is, again, it's a mixed venous amount.
Beautiful. So you take a sample out, and in this case, you will run it through the blood gas machine. So you get your P mixed venous O2. And then because you're not taking your saturations from there, the way you get the saturations of that is you'd use your oxygen hemoglobin dissociation curve, which your arterial blood gas machine calculates for you, and take that saturation level.
Yeah.
Beautiful.
Cool. And your CC prime O2, which is your end capillary one, is calculated a little bit differently. Obviously, you can't chuck your catheter in all the way to the end capillaries. So, Lahiri, how do we get that content?
Yeah, you have to do it theoretically. You have to use your alveolar gas equation. So if you remember, your expected P alveolar O2 is determined by your FiO2 times your barometric pressure. So that's 0.21, let's say, times 760 take away your humidified water pressure, saturated water pressure, which is 47. So that's 760 take away 47 comes to 713. So now you got 0.21 times 713, which is about 150. You then take away your P alveolar CO2, P arterial CO2 over the respiratory quotient. So that's roughly 40 is your rough P arterial CO2 divided by 0.8, which is the average respiratory quotient for people on a normal diet. And when you plug all these numbers, you've got 150 was the first part. 40 divided by 0.8 is about 50. So that comes to 100 in most situations. So you can then calculate, you now assume that there's no diffusion problems, so you've got to make some assumptions here, and you imagine that your end capillary is exactly your P alveolar O2. That's how you get that. You can plug this into a oxygen hemoglobin dissociation curve, make sure your parameters all appropriate, and then you can calculate your saturations based off that.
Yeah, exactly.
And it's weird, like, so roughly the shunt equation, it comes to like, as you can see, actually, I'll put this diagram up again. This is a concept, right? Like this QS here, it really is, you're just trying to find a ratio of this to this. And they say it's like roughly less than 30%, which seems like a lot. But if you take all the venous admixture, which is, lots of suboptimal segments, and you take your, true shunt, and you take your physiological shunt and the occasional pathological shunt, you can imagine that it all adds up to be suboptimal. But that's just a useful concept. So there's no artery that looks like this thing, this arrow here, QS. There's no artery that's just bypassing. This is a concept to help you calculate how much, non-oxygenated or venous admixture is existing in this patient. And you can imagine a setting where maybe over time, as you're treating a sick patient, you try a treatment and you see how they progress. And if they're progressing in the right direction, as judged by these kind of parameters, then you're on your way.
Yeah, perfect.
Yeah, good. Let's go to. Is there anything else that we need to talk about?
I guess we could talk about the Iso-shunt diagram and the effects of oxygenation on there. Obviously, with venous admixture and sort of shunting, one of the big things is the oxygenation. So I think there's been previous questions about what the effects are going to be of oxygenation when people are shunting. So we'll bring up that ISO shunting diagram, but basically for those that are listening, when it gets to above 30% of shunting, so when your blood's being shunted greater than 30%, no amount of increased oxygenation or increased amount of FiO2 that you provide this patient is going to have an effect on your arterial PO2, and that's because the shunt just cannot compensate for the amount of increased FiO2.
Well, your increased FiO2 can't compensate.
Yeah, sorry, the other way.
Yeah, that's right. Hey, so everyone can see on the screen again, check out YouTube, but this diagram's from Nuns. You could literally just Google Iso-shunt diagram. And as you can see, so imagine you're asked to describe this. Often you'll have complex diagrams which you're asked to describe, and it's really important just to say true statements, because let's say you've never seen this diagram before. It'll be pretty intimidating. And trust me, this primary exam has plenty of intimidating diagrams. The first thing you say is hopefully you know what it is, or there's a title. So this is the Iso-shunt diagram showing virtual shunt lines. On the x-axis, this is your independent variable. This is the one where the person doing the experiment is increasing your inspired oxygen concentration, which you see on the x-axis, goes from room air up to 100%. And then we look at the response. What does the arterial PO2 do as you increase oxygen? We can then see that there's at different levels of shunt, your arterial PO2 changes in different ways. And like you said, when you look at 30% shunt, it looks like increasing FiO2 just doesn't help. And you could explain this by saying that, well, if you increase your FiO2, all you're doing is hypersaturating dissolved oxygen. Your oxygen content's probably as maximally saturated as it can be in hemoglobin. And so the extra dissolved oxygen can't suddenly attach to all of that massive shunted blood that doesn't get exposed otherwise to the alveolus. So it just can't make a difference. I'd say, so when they created these shunt lines was to calculate, in ICU patients, calculate what level of shunt they had. So imagine a sick patient, they would increase the FiO2, take a gas, and then plot it on a diagram. And if it matched one of these shunt lines, you could say, oh, this patient has 15% shunt or 25% shunt. So they could see, the level of shunt they had. Now, I think that there's probably a limitation with this. We're talking about shunt, right? So this should be talking about venous admixture. So if it was due to VQ inequality, but not pathological shunt, then you may have better compensation and better arterial PO2 response to increasing FiO2. Whereas if you had just total loss, a true shunt effect, pathological, physiological, or whatever, and it was not predominantly due to venous admixture, then it truly is bypassing any extra oxygen coming into the alveolus. So I'd say that's just the extra thing with this. But if you're getting asked these kind of questions, I'm sure you're doing extremely well.
Yeah, exactly.
Good. I think that's pretty much covering it. Good. Anything else to add there?
No, I think that's about it. Having that snappy definition of venous admixture and sort of thinking about what encompasses it will really guide your answer in this section.
Beautiful. Hey, thanks very much, Arthur. Thanks for doing all that prep. Again, really great to get you onto, you're studying it, you're learning it, and then we get to have a discussion. And it's so useful because, even though I'm kind of going over some of these concepts and refining them, that's part of the process. Like everyone who's studying, when you study the first, second, third time, it's about, we're playing this game, like the words mean very specific things, and often we won't be used to it. It took many, many runs of this to refine the words and know what certain things mean and how to explain it. So yeah, this is good practice and you're doing extremely well with it as well, Ajit. So thanks so much.
Thank you all. See you next time.
See you next time. Bye.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.